Hello, everybody. We are back, and this session is an exciting one. It's dealing with male infertility. And we have two speakers. The first one is known to everybody, Dr. Sherman Silber. And Dr. Sherman Silber is a renowned pioneer in microsurgery in infertility, is considered one of the world's leading authority on IVF, mini IVF, sperm retrieval, ICSI, vasectomy reversal, male infertility, tubal ligation reversal, egg and embryo freezing, ovary transplantation, and reproductive biology clock. For over 38 years, Dr. Silber has originally developed all of the most popular fertility treatments used all around the world. For this meeting, I asked Dr. Silber to discuss with us a unique topic, the journey of the sperm in the male reproductive organs. So, Sherman, stage is yours.
Well, thank you very much, Zev. It's always great to be able to be part of IVF Worldwide and what you're doing to promote our new knowledge, especially in this era of COVID. So this topic is something I hadn't thought of even giving, and Zev brought it up to me, and it really excited me because it's an opportunity to really go over the basics of spermatogenesis and sperm transport that really has tremendous applications in the clinic. And many gynecologists are kind of stuck because they don't know this information, even though they have to do their treatment, whether it's IUI or deciding about a urologic consult, whatever it is. This is what gynecologists need to know. I first went into great detail in preparing these slides, and now I've cut it down dramatically because I want to stay within time. But I can certainly give a more detailed follow-up at a later date. But let me get ahead with this now. The journey of the sperm really starts in the epiblast, in the early embryo of the male fetus. It all starts here in the early epiblast. I mean, this is 9 days of embryo life, when cells that are destined to remain eternal, germ cells, are separated from the rest of the developing embryo. Now, this has to happen. These cells that are going to become sperm or eggs have to be separated away from all the other cells that are undergoing somatic differentiation. These are the eternal cells that will lead to future generations, obviously. Now, somewhere between 3 and 6 weeks, but mostly in the human, it's 6 weeks of fetal life, these cells, these PGC specified cells from the epiblast migrate finally into the embryo proper up to the dorsal ridge. And in this process, they are differentiating into PGCs because they are pluripotent cells. They're like stem cells. And if they're not fully differentiated into primordial germ cells, by the time they reach the gonad or in the gonad, they become tumor rests, just like any stem cell would become if it's not located in its proper niche. And in fact, testis cancer and even ovarian hematomas are related to these stem cell rests not having fully differentiated. So the Mullerian and the Wolffian ducts are both present at 6 weeks of fetal life, and they lie parallel to each other in the fetus before sexual differentiation at 6 weeks. Then the Mullerian ducts regress in the male under the influence of AMH secretion. That's what I never thought of AMH when I was in the early days of my medical practice as being an indicator of primordial follicle reserve or ovarian reserve, but really what it is, anti-Mullerian hormone. It's 6 weeks of fetal life. It's secreted by the testes and causes Mullerian ducts to regress. The Wolffian ducts then are enhanced under the effect of fetal testosterone. So I'm sorry about that phone ring. I apologize. The Wolffian ducts develop into epididymis, vas deferens, and seminal vesicles, and the prostate gland. The remnants of the Mullerian duct persist in the male as the appendix testes, the verumontanum, and just in front of the prostate. So I'm going to show you all this. It's not just going to be words. So the Mullerian ducts become fallopian ducts, uterus, upper vagina in the female. Wolffian ducts in the female become the round ligament and the periurethral glands, which is the female prostate. Inside every male is a little female, and inside every female is a little male. And here's just a diagram to show you that we're all neutral at 6 weeks of fetal life. But what happens then is that it's the gonad, which is neutral, is either going to be a testis determined by the SRY gene, or it's going to be an ovary. And the testis, if it becomes a testis, secretes Mullerian inhibiting factor that causes Mullerian ducts to regress. And you'll see every male has Mullerian duct remnants, and I'll show you that in a minute. And in the female, the Mullerian ducts develop into the uterus and upper vagina and fallopian tubes, but without testosterone secretion, the Wolffian ducts just degenerate. But there are still remnants of it in the female, such as the round ligament and her periurethral glands, which are truly the female prostate. So here, in a male that's simply about to undergo a TESA procedure, you can see his uterus, upper vagina, and fallopian tubes very, very clearly. It's called the appendix testis. It's present in every single male. This is not an abnormality. This is what's left of the Mullerian duct in the male. And you can almost make it out pretty well, the uterine artery, fallopian tubes, and even where they come together. Now, this is just another view to show you that it's right near the head of the epididymis, and you see this in every male. Now I'm going to show you the remnant. Let me just stop this for a minute. I'm going to show you the remnant of the cervix and the upper vagina in the male. We're going through the penis. It's an old video that I did a long time ago, and I'm gonna show you. Look carefully, and you'll see here the verumontanum, we call it, and there it is. And I'll show you again. There it is, and you can see that little lump, which urologists for 80 years have used as a landmark when doing a TUR, and that's the verumontanum. I'm gonna show this a little better here. Yeah, I got control of it now. And if you look carefully at it, you can just see it's the cervix with the cervical external os right there in front of you, and it's present in every single male. Now, when you look at just at the gonad itself, there's a difference between the female and the male, but they're really the same. In the female, well, in all of us, there are these sex cords, embryonic cords, that in the female are going to become follicles with granulosa cells, and in the male are going to differentiate into seminiferous tubules with Sertoli cells, which are the equivalent in the male of the granulosa cells in the female follicles. So what happens when the PGCs, and I'm starting this journey of the sperm very early, what happens when the PGCs reach the testes? Well, they are suppressed from functionally expressing their pluripotential or cancer cells potential by Dazzle and VESA genes during their travels, even though they must preserve that pluripotentiality become germ cells. So if you measure their expression, their pluripotential, but Dazzle and VESA shuts it off so that they don't become cancer cells until they're finally safeguarded in the ovary and in the testes. If they meet an ovary instead of a testis, they are induced by retinoic acid from the adrenal gland to differentiate by upregulating STRA8, and they enter meiosis and become oocytes. But if they meet a testis instead of an ovary, the Sertoli cells protect the entering PGCs from retinoic acid, and they differentiate into spermatogenic stem cells instead, which I abbreviate as SSCs. So Sertoli cells in the fetal testis antagonize this retinoic acid, so STRA8 is not upregulated, and therefore the PGCs that enter the testis do not enter meiosis, and they become the ever self-renewing spermatogonial stem cells. Totally different in the male than the female. Now, if you look carefully at these Sertoli cells, I'll show you later on electron microscopy, they're very confusing because you see a prominent nucleus and a prominent nucleolus, and you don't see much of a cell outline because they're amoeboid. These are just amoeboid phagocytosing type cells, and all you really see, other than hazy outline, are the nuclei and the nucleus and the prominent nucleolus. That's important when we come to evaluate TESA procedures and finding spermatids for TESA. So this is just a diagram showing you what I'll tell you in a minute, that the type A spermatogonia, the dark spermatogonia, contain stem cells that are self-renewing. But really, pretty soon they're making pale spermatogonia that are progenitor cells that rapidly divide and ultimately become millions of sperm. But it starts with just a very small number of spermatogonial stem cells. So spermatogenic stem cells stay in the basement membrane of the seminiferous tubule and renew very slowly. And in fact, remember I talked last time about pressure being crucial for slowing down development, and that's how the primordial germ cells or the primordial follicles in the ovary remain static and are only slowly released and recruited. Well, the same thing is true of all stem cells. It's that pressure within a basement membrane that allows these stem cells to renew very slowly. Well, the slow self-renewal of spermatogenic stem cells is very, very important, and for all stem cells in the body to limit the number of mutations over time. Otherwise, sperm in men who are 30 years old would be filled with mutations that could be damaging. So these slowly developing stem cells make progenitor spermatogonia when they multiply at the fastest rate, but they can't self-renew themselves. Only the stem cells can. Progenitor spermatogonia eventually are committed to making differentiated spermatozoa, and they can't self-renew. So let's explain the importance of that. So spermatogenesis in the human can be divided into 6 stages based on spermatid maturation, from round spermid to elongated spermatid with a tail. In rats and mice, these stages of spermatogenesis pass along a seminiferous tubule, and I'll show you this in a minute, in an orderly wave. So if you were to do a biopsy TESA on a rat or a mouse, you might see no mature sperm at all. You'd only see spermatocytes. In the human, God has made this so beautifully. We have chaotic cellular associations in every area, so that wherever you happen to do a biopsy, you will see all the 6 stages of spermatogenesis. That's very important. TESA really, for a non-obstructive azoospermia, would not work in the rat or the mouse or most animals, but in primates and in humans it would. So here's just a diagrammatic organization. And on the bottom are the dark type A spermatogonia, which contains spermatogenic stem cells. We don't have good markers for spermatogenic stem cells, but we know they're contained within this basal layer of dark A spermatogonia. And then they go to pale A spermatogonia, and the pale A spermatogonia very quickly go to B spermatogonia, or that is the B spermatogonia very quickly enter meiosis. So what happens in the human is that retinoic acid, which caused meiosis in the oocyte immediately, in the Sertoli cell is strictly regulated so that it is only active in what you see is stage 3. And if you look at the 3rd row where it says PL, that is the beginning of meiosis. And then meiosis proceeds from leptotene to pachytene to secondary and then to spermatids in the top rows. And so retinoic acid still causes meiosis in the testes, and it's doing it all the time because what's preserved are spermatogonial stem cells, so men do not run out of sperm. Now, this is just to show you the fact that upper scene shows how there's a wave of spermatogenesis in most of the other animals other than subhuman primates. And there's a wave of the stages. So if you hit the wrong stage, you're really not going to find any sperm. But in the human, it's a chaotic arrangement of stages 1 to stage 6. And you really have to be very sophisticated to recognize these. I'll show you in a second. So here's a typical spermatogenic tubule in a man with normal spermatogenesis. And note, you're not going to see the tails. And that's simple because the tails are tiny. And so in any histologic section, unlike in Tessa preparations, you're only going to see the head of the sperm. So you can see in the upper left hand the head of the sperm in a completed spermatogenesis, but all you see is round spermatids in or pachytene spermatids in the rest of the tubule here. But if we understand it carefully, you'll see that stage 5 is where we have the lovely condensed spermatids. Stage 4, we just have the developing round spermatids, and stage 3, even less developed round spermatids. And you will never see a tail, either in the mature sperm or in the round spermatids on histology. You'll only be able to see them with electron microscopy or with a Tessa wet procedure. So here is just stage 2. Note I showed you there stage 5, 4, and 3. Here's stage 2 where you see plenty of sperm. So spermatogonia divide at different rates. The dark type A spermatogonia proliferate the slowest, and some, but not all, actually are spermatogonial stem cells. That's where the stem cells are. Pale type A spermatogonia and type B are the progenitors, which divide at a very fast rate, but they can't self-renew. So it's a beautiful system where you can protect the sperm from accumulating mutations over a lifetime of the male by the fact that the self-renewing spermatogonial stem cells divide very, very slowly. But in order to have lots of sperm, the pale type A are committed despite initial self-replication to making differentiated spermatozoa, and they divide extremely rapidly. So the slowly dividing SSCs make rapidly dividing progenitor spermatogonia. The SSCs also make more SSCs. It is the slow rate of SSC proliferation that helps to minimize occurrence of lasting cumulative mutations. Mutations that occur in rapidly dividing spermatogonia are not cumulative, only mutations in slowly dividing SSCs. Nonetheless, there is still enough continual mitotic divisions of SSCs to create a mutation load of 2 new mutations per year. This doesn't happen with oocytes. So that's why I've always said the male is the origin of evolution, because that's where mutations occur. They don't really occur in the oocytes that undergo continual rapid duplication. But nonetheless, the slow division of the spermatogonial stem cells helps us just from becoming monsters. It just leads to evolution. So the 6 stages of spermatogenesis each last 16 days. You saw that there were 4.5 cell layers to become spermatids, and therefore complete length of time to make a mature sperm from its beginning, from a progenitor stem cell, is more than 72 days. So if it's just 72 days, though, why does it take 4 months to several years for sperm to return after chemotherapy or treating Kalman's with gonadotropin? I mean, we know after chemotherapy, we may very well see spermatogenesis return magically and 3 years later after azoospermia. So why is that the case? Well, after radiation or chemo, the pale, rapidly dividing spermatogonia are completely depleted. They are gone, and the man is azoospermic. If there's any recovery of spermatogenesis, it could take several years. And recovery is only from those slowly dividing dark spermatogonia pool, which contain the SSCs. So we can find those dark spermatogonia, and we can tell the man whether he is going to, from a biopsy, whether he's going to regain spermatogenesis or not regain spermatogenesis. After discontinuation of testosterone, however, it's different. Recovery is usually in less than 6 months because the pale spermatogonia have not been really depleted. In other words, you're not depending on the stem cells. You're just suppressing the development of the pale spermatogonia and progenitor sperm cells. You're just preventing that. And so you have to wait the 72 hours for spermatogenesis to complete it and 11 hours of transport through the vas deferens. So we see after stopping testosterone, 3 months, maybe at most 6 months later, we have recovery of spermatogenesis because the stem cells have not been hurt at all by testosterone inhibition of FSH or LH. So all the steps of spermatogenesis are located within this amoeboid-like Sertoli cells. They nourish the spermatogonia just like granulosa cells nourish the oocyte, and they nourish the spermatocytes and the maturing sperm. Sertoli cells are the male version of granulosa cells, and spermatogonial stem cells are self-replicating, unlike the female where there are no new oocytes produced. So here is just, again, another view of a Sertoli cell-only case in an adult. So you can see that it's just the cytoplasm is just amoeboid, and it really is absorbing and nourishing the developing sperm cells as well as the spermatogonia. And what you see prominently is just the nucleus and the prominent nucleolus of the Sertoli cell. And in some Tessa cases where people claim they found round spermatids, they really haven't. All they've found is Sertoli cell nuclei, and I'll show you that later. Now, this is electron microscopy just to verify and show you what happens. Now, if you see those cells with the bright white, sort of glowing acrosomal cap, those are round spermatids. Now, the minute that acrosomal cap disappears, a tail develops. So you should never be confused about whether a round cell in a Tessa specimen is just is really a round spermatid or is a Sertoli cell nucleus, because you will see a tail once that glowing acrosomal cap disappears. And if you look farther to the right, you can see developing condensing oval spermatids that are about to be released. And there you can see specifically how the sperm is nourished and almost ready to be released from the Sertoli cell cytoplasm. And as it's released, it will always carry with it a cytoplasmic droplet. So there you can see a mature sperm that's ready to be released, and it just drags with it a cytoplasmic droplet. That droplet doesn't interfere with fertilization. You'll always see it with Tessa cases, but it's just a remnant of the old Sertoli cell cytoplasm that this sperm spent its early life in. So once spermatozoa are fully developed, they are released by the Sertoli cell into the lumen of the seminiferous tubule, and there is usually a cytoplasmic droplet. This droplet is always present in Tessa's sperm, but is released during transit through the epididymis. In the human, there are always spermatozoa with tails in the testes if they're around spermatids. So there you can see, if there are round spermatids present, there are also sperm present. And that's the round spermatid controversy. Here you can always see this acrosomal vesicle in a round spermatid until the tail develops. But these are just Sertoli cell nuclei that you can readily see on Tessa in a case where there really are no sperm. Now, if you see if you see what looks like round spermatids, if there are sperm present, you can also see the acrosomal vesicle that glows up on phase contrast and is easy to see. So what we're doing with Tessa is we're not trying to just find immature cells. It doesn't work. What we're doing is realizing that there are, in 60% of cases, normal spermatogenic tubules located in a sea of Sertoli cell only, and not enough sperm being produced to actually make that journey all the way through the reedy testes and from the seminiferous tubules and to the head of the epididymis and the tail of the epididymis and the vas, and that journey that we're going to talk about. Now, again, SSCs survive initial chemotherapy, even though cancer cells do not. That's very important to know, because you should always freeze the testes of a prepubertal cancer patient after they've had their initial rounds of cancer treatment. And then you'll have no trouble transferring those spermatogonial stem cells back to him when he's an adult without any recurrence of cancer. SSEs produce spermatogenesis and restore fertility if transplanted into the reedy testes. There should be no cancer cells in the testes of the prepubertal boy with leukemia after his initial remission. The more sturdy SSCs, much sturdier than cancer cells, will survive the initial chemotherapy and can be frozen before the more extensive later bone marrow transplant because there's still cancer cells in his bone marrow. They can then be thawed, these SSCs, injected into the reedy of the patient after he is cured of the cancer. It is not until the spermatocyte stage that meiosis begins with homologous recombinations lined up. On histologic inspection, you can easily see condensing chromosome of homologous chromosomes, so you can easily see the packaging spermatocytes. But they are held together by a centromere forming the packagings, and like chromosomes then separate from each other, resulting very briefly in secondary spermatocytes. And you will never see these secondary spermatocytes on histology because they last so briefly. This is just to remind you that retinoic acid is what induces meiosis in spermatogenesis as well as in oogenesis. It's just a different timely basis. So in maturation arrest, you will often see 60% of the time a few spermatids, which you can see at 12 o'clock. And that's why TESA works, not because you can find round spermatids that you can inject. Because if there are round spermatids, we guarantee you in the human, there will also be condensing sperm, which will work much better for TESA. Here's another example, maturation arrest, but you can see a few condensed spermatids that are about to be released. So we hardly ever see secondary spermatids on histology because they quickly divide, complete meiosis II, as the centromere finally divides and becomes 1N. That results in haploid round spermatid, which quickly begins to grow a tail, as well as condense and elongate its chromatin in what becomes the head of the sperm. Before growing its tail, the round spermatid is definitely identified by the presence of an acrosomal vesicle. So the early papers on Rossi were mistakenly injecting Sertoli cell nuclei. Bob Edwards pointed this out a long time, saying the round spermatids simply glow. And we laughed at him, but of course, as usual, Bob was correct. There you can see the electron micrograph demonstration that just as the acrosomal vesicle in the lower left is disappearing, the tail is beginning to form as the spermatid develops. And you can see this again directly on electron microscopy, the glowing round spermatids before the tail is developing. And you can also see on the right upper some condensing spermatids that have a tail. Now, what about the hormonal regulation of spermatogenesis? This is really important to understand, and I'm going to be running out of time very soon, and I think this is important enough. I haven't even gotten into why IUI is not as good as intercourse for getting sperm to the egg, and I'm going to get into that if I have time or in a subsequent lecture. But we know pulsatile GnRH secretion from the hypothalamus travels in an apocrine fashion to the anterior lobe of the pituitary gland and stimulates, but only permissively, the release of FSH and LH. Just like in the female, the release of FSH and LH timing is controlled by the oocyte and not the GnRH, which is just a permissive pulsatile release. In the male also, it's the production of inhibin and spermatogenesis with feedback that controls the FSH release from the pituitary, not the GnRH. So with FSH only, like in the fertile eunuch, a rare condition, the testes produce only low numbers of poor quality sperm. So there is only FSH and no LH in these men, and we call them the fertile eunuch because they have sperm, but the sperm are terrible and they're really not fertile. LH is required for both quality and quantity of sperm. FSH, however, we know is necessary for initiating the completion of spermatogenesis, and I'll explain to you that when I talk about the treatment of Kalman's in the next slide. So spermatogenesis beyond spermatogonia stage does not ensue until puberty, when we have both FSH and LH. So Kalman syndrome is this azopermeous syndrome caused by the lack of GnRH and therefore no FSH or LH. So Sharon showed so many years ago, if you give just HCG for 3 months or even up to a full year, you get what appears like normal spermatogenesis, but only up to the Pachytene spermatocyte stage. So you get maturation arrest, and the testis looks like it's well developed. You need to add FSH to that in order to initiate this completion of normal spermatogenesis. You will have maturation arrest with LH only unless you add FSH. But after you initiate the completion of spermatogenesis with FSH, all you need for the rest of your life to continue spermatogenesis is the HCG alone to maintain spermatogenesis. So the major cells to look for in histology are pachydian spermatocytes and spermatocytes. The control of spermatogenesis is inconstant in every species. Sperm production only depends on the volume or the number of PGCs that reached the fetal testes and became SSC when that male was a little fetus. You cannot increase spermatogenesis by increasing gonadotropins. You can only decrease by giving androgen to decrease FSH and LH, but you cannot promote spermatogenesis by increasing the FSH or LH level. There are huge variations in sperm count, but that is only because of sperm transport. If you just look at a normal fertile student who had sperm counts done every week, you can see it can be 180 million or it can be less than 10 million in the same person. But that's not the daily sperm production rate. If you get a sperm count every single day, so you're eliminating the effects of sperm transport or sperm storage in the epididymis, you will then get what's called daily sperm production rate, but no one does that. And so the sperm counts fluctuate tremendously, not because of a variation in the rate or speed of spermatogenesis or anything that your treatment has done, but just because of fluctuations in sperm transport. And so all the treatments with Clomid or Varicocele that you hear urologists tell you about only appear to work if you start out with a low count because of regression toward the mean and a highly variable factor. But if you did a varicocelectomy or put a man on Clomid that started out with a high sperm count, it would look like you're hurting many of them because the sperm count would be much lower subsequently. That's just a mathematical phenomenon of regression toward the mean caused by the high variability of sperm count, which is related to sperm transport only. Not that sperm count doesn't matter. This is a study going back 34 years that hasn't been duplicated by Baker and Berger, showing that men with low sperm counts will get a fertile wife pregnant, even with less than 5 million sperm per cc. But the success rate, this is with natural conception, is lower than if they have high sperm counts. And you can see that that's compared even to the standard graph, the beautiful graph that it's all we have by Vesey et al. Of nulla gravida women who are discontinuing an IUD, and of normal sperm counts by McLeod and Gold, which goes back to the 50s. So we know from those early studies of natural conception that sperm counts affect the time until conception and the rate of conception, but younger women get pregnant relatively quickly as long as there is some sperm present at all. So I'm just going to show you a quick variety of sperm. Now, in every man with a normal sperm, and you can see these hyperstimulated sperm, there are going to be dead sperm as well. And there are going to be sperm that swim in a straight line, or sperm that swim in circles, and abnormal appearing sperm heads, and sometimes just rare normal sperm. So there's a variety of sperm in every single man's sperm count. Here's just a pinhead. There's no DNA whatsoever in this sperm tail. And here's a very twitching sperm that's never going to fertilize, right next to one that could fertilize and one that will have a doubtful success. And so when we try to talk about sperm DNA fragmentation, it's stupid because in every single ejaculate, you're going to have good sperm and bad sperm in terms of morphology and motility. And it's mostly related to degeneration of the sperm, which I'll show you in a minute, that we've studied with electron microscopy. And all the DNA fragmentation is, you're just finding the sperm that are the poor sperm, and we can show it to you on electron microscopy much better than with your COMET assay. So now the completed spermatomazoma are ready to leave the testes, and this is the stage of sperm transport that's very important clinically for azoospermia. Completed spermatozoma are released from the Sertoli cell and are transported from the seminiferous tubule by muscular contractions to the reedy testis and vasa efferentia. And the reedy and vasa of the sperm is transported by cilia, however. Now that's important for vasectomy or obstructive azoospermia. These cilia in the reedy testis and the vasa efferentia protect the seminiferous tubules from back pressure after vasectomy, but it doesn't protect the epididymis. So you have blowouts and secondary blockages in the epididymis after any vasectomy. but the anatomy and physiology of the reedy is completely misunderstood in almost all textbooks and atlases. I'll show you this quickly, and you can stop me when I'm out of time because I can keep talking. I have great slides. But this is the classic picture of the reedy testis and epididymis in a typical atlas. Totally wrong. Here's another one from my original book on male infertility. Completely wrong. Like the reedy testis is a gathering delta there right near the edge by the vasa efferentia. Completely wrong. I'll show you why it's wrong. This is completely wrong. These are classic atlases. Now, this is the closest to right. This is from Sabata, the Italian atlas from many centuries ago. And it shows that the reedy testis is kind of a straight line gathering duct. And it's a little wrong because it's more centrally located. And I'll show you that in a second, just with our ultrasound. There you can see it's almost centrally located. We're about to inject SSCs into the reedy testis. This is actually a human. And this is the collecting system for sperm from all over the seminative tubules that eventually drains near the head of the epididymis into the head of the epididymis. So the corpus and cauda epididymis appear to be only 2.5 centimeters long, but actually is one single long coil tube that's 6 meters long, and it's mesonephric in origin. The caput epididymis is a very short continuation of the vasa efferentia and is metanephric in origin. Therefore, with CAV, congenital absence of vas, there may be varying lengths of corpus or caudus epididymis, or even some vas, but even complete absence. But there is always a caput because the caput epididymis is not mesonephric, it's metanephric. Epididymal transit time is about 11 days, and sperm are normally viable there for 2 to 4 weeks. But, I'm not going to get to all of it. But the volume of the ejaculate is only 5% from the testes. 95% are really from the seminiferous tubules. And this is interesting. At the time of orgasm, this fluid, 95% coming from the seminal vesicles, which came from the prostate gland, is what pushes the vas and epididymal sperm into the bulbous urethra of the penis. Emission is the feeling of ejaculatory inevitability, and that's the contraction of the seminal vesicles to push the sperm into the bulbous urethra. And then ejaculation is caused by the forceful contraction of this bulbous cavernosus muscles that are just distal to the prostate gland. And in obstructive azoospermia, the worst sperm are the most distal. And that's where I'm going to show you the idiocy of relying on sperm DNA fragmentation. So there you see in the distal epididymis of obstruction, you see that there is obviously sperm DNA fragmentation because these sperm have died of old age. Sperm die of old age within about a month, and every ejaculate is filled with sperm that have died of old age and are undergoing DNA. We call it DNA, so it sounds like a big deal. It's chromatin degeneration, which occurs when the sperm are old. That's all there is. It's senescent sperm. Now, when you're doing tests, okay,
yeah,
that's all. I said you can interrupt me anytime.
Maybe you summarize the lecture in 1 or 2 sentences as 1 or 2 things I would like to ask you when you finish.
I'm going to summarize now because I know I warned you I'd be going over, and I can give another lecture because there's a whole issue of how sperm are then transported to the fallopian tube. But I'll just summarize with a few take-home points. You can't increase spermatogenesis or sperm count by giving clomid or gonadotropins. And a second point is that you must do a testis biopsy on every prepubertal boy with cancer, but you should do it and freeze the testis biopsy, do it after their initial round of chemo, and then there won't be any cancer cells in the testes, but you will have preserved his spermatogenic stem cells for later in life. And a third very important point is that inside of every male is a remnant of the female Müllerian duct, and inside every female is a remnant of the Wolffian duct. So when the female has urethritis, which is a constant bane of the female, it's no different than prostatitis in the male. So we are different, but we're really the same. So that is a sort of a quick summary of the points I wanted to make these details on.
Sherman, the topic is interesting, but the lecture was fascinating. Very, very interesting. And obviously, we should come back to you to hear the full version of your lecture. But before we leave, I would like to ask you two questions, very, very short answer for the question. What is the earliest type of spermatozoa that can fertilize the egg?
Oh, okay. So you can fertilize the egg with round spermatids. We know that can be done, but you do have to activate because you don't have a developed acrosome. You just have that acrosomal vesicle. And so you do have to activate either with electroporation or calcium ionophore. But I'm telling clinicians that that's pointless because if there's a round spermatid seen on Tessa, keep looking and you will find an elongated sperm with a tail. And then you don't have to even activate.
And the other question is there any point to choose the sperm for ICSI in high magnification, much higher than what we are doing today?
Okay, so that's IMSI versus ICSI. And in my next lecture, I really have some beautiful demonstrations of IMSI and ICSI and what the difference is. So IMSI is beautiful because you can really see those details of the sperm head much better. And I'll show that to you. IMSI at 800 magnification, which is, as soon as you go higher than that, it becomes very difficult to manage. But IMSI at 800 is not much different than ICSI at 400, although usually you do ICSI at 200. So IMSI gives you a much better view and it's beautiful. But randomized controlled trials have shown that that picking the sperm at that higher magnification does not give you either increased fertilization or increased baby rate over just picking the sperm with standard ICSI magnification. So it's a beautiful thing to do. I'm not against it, but the randomized controlled trials, and there have been quite a few of them, have not shown any difference with IMSI over ICSI.
Thank you, Sherman. We have to stop here. And I promise the audience that we will come back in a very full version of this lecture, which is very, very important. So thank you very much for your time. And thank you very much for sharing this information with us.
And thank you for your attention. I appreciate it.
Thank you.